morning, and thank you for joining us for our session today, Financing a Strategy to Address Social Determinants. My name is Wendy Armendariz, and I have the pleasure of sharing the stage with some great leaders in our community. On our panel today, we have Lori Bottrell, CEO of Mercy Care, Brenda Schmidt, founder and CEO of Noble, Hannah Scott, Policy Director for Arizona Community Health Workers Association, and I'll close it out with our health center's perspective, being on our journey towards SDOH. We'll be watching the session here throughout our time. We'll be watching for questions. Please feel free to enter your questions in the chat. We'll leave some time at the end, and we'll help to respond to as many questions as we can. And so now I'd like to turn over the floor to Lori.
Great. Good morning, everyone, and so excited to be here to talk about such an important topic. So, I think we're getting to the slides, so we'll work through that. So I really wanted to start out just kind of talking for a moment, for anyone who doesn't know, Mercy Care is a Medicaid plan here in Arizona. So we're actually in all the different lines available under Medicaid, and so serve lots of different populations, including foster care and DD population and all tech. So we really gain a perspective of all the needs throughout the state and really try to focus our time on that. So if we move to the next slide, I wanted to talk about two key ways that we really focus on it. And these are not the only ways, but they're just two that I thought were most relevant and probably drive most of our information. So one is community reinvestment funds. So every Medicaid plan actually is required to invest 6% of our annual net profit back into the community, into programs that benefit the community, serve low income, really advance kind of social determinants and other items. So I'll talk about a program later where we've really kind of combined together with all of us having the requirement and kind of bringing in others, but it also has just really given us some dollars and opportunity to really invest back in the community and as we all know, help serve our members and improve health outcomes. And then secondly, we've really been focused through our value-based agreements as well. So some of it has to do with really increasing the what we now, call Z codes, but the, ICD-10 codes that really give, we think by doing that, it really supports the providers in really thinking about that and doing those evaluations and kind of making that part of the discussion, not just how are you doing physically or even behavioral, but how do you really focus on all the things that impact individuals' health. And then also it gives us better perspective once we start aggregating that data to really look at what programs or what are really some of the needs and the amount of Z codes is amazing that it has. It's not just housing and food, it's quite a number of things. So it gives us really good perspective, not only kind of where some of our members might be struggling with things that might be different than maybe in a urban versus rural kind of population, but also even we can break it down by zip code and things like that to really make sure we're addressing programs in the right way. So anytime we can get that data, certainly really important. If we move to the next slide, like many of you out there, we've seen just some great impacts when we really do invest in this. So the results, this is from a NORC study that was done related to individuals with SMI in our REBA contract, and just really impressive results when you looked at adding supportive housing wrapped around, really decreases the cost for individuals, certainly less kind of ER visits and, overall, facility costs. So I think we all know, but, this is even really good data that really shows the value of housing and then others that really impact our overall outcomes. If we move to the next slide, these are the areas that, at least at Mercy Care, there's so many things everyone, all of us can be focused on. We've really, work with our board, which is Dignity and the Ascension representatives. And these are really the areas of the last few years that we've really been focused on. So addictions, and that's not just the opioid, but, all levels of addictions. We see that as such a critical component, especially with COVID. We've seen a real uptick in that area and really needs with that. Housing security, like we just talked about, we've seen incredible results, and we all know with the housing market, it's even more important to really be focused and moving some dollars towards housing. School-based services, again, especially with COVID, just such a really important time to be connecting with individuals that are in school. And then lastly, women's health. So for us, food as well has been important, but we tried to say there's so many things we could be doing. How do we really drive to those? So in the next couple of slides, I'll show you a couple of things that we've done. The next slide really talks about a pretty innovative program that we've done here called Home Matters. And hopefully some of you have heard about that, because we've really been out trying to create some excitement in the community around it. But what we really did is said, hey, as Medicaid plans, we all have dollars and we can each go do a housing program, but why don't we kind of pull that together and then also look to others. So we were able to get CVS, Aetna, United Healthcare, and Dignity to also contribute dollars to it. And our goal right now, we're at about 37 million, with primarily kind of low interest loans as being part of that, and a few million in the grant side. But how do we get to 100 million? And so how do we show our commitment to housing and healthcare and all of that? But how do we go to others, whether it's, government funds or, budgets that are out there, or federal dollars that are out there, or banks or other kind of non-traditional healthcare providers, to say, hey, we've already started something together. We've put dollars forward, but we want you to come into the mix as well. And we really believe by doing that, we can really have a much bigger impact overall. We've already awarded 3 different entities, 1.2 million in the fall, and we're getting ready to announce the award winners for our next grant as well. And then we'll be having another grant coming this summer. So really excited about the impact that we've had, but I think it's a great representation of taking not just one entity, but kind of bringing everyone together to really think about ways to fund and come together to make our dollars even go further. And then lastly, I thought I'd just share some of the other things that we've really focused on. Really this Double Up Food Bucks has been, really important, again, especially during the pandemic. As you can see, as we looked at how to spend dollars in the last year, we put a lot of that towards the pandemic support, but also through other programs as well, and really try to, make sure it's in alignment with what we're doing. But again, really utilize some of those community reinvestment dollars to really make sure we're having the right impact in our community. So with that, I think that's the end of my slides, and I'll turn it over to Brenda.
Thanks, Lori. And so Brenda Schmidt, I've been a serial entrepreneur here in Phoenix for the last 15 or 16 years. Always focused on vulnerable and underserved populations is just a huge passion. And so the previous company, Solera, was trying to solve the problem of how do community benefit organizations providing evidence-based programs that are improving the health of individuals can actually get paid through medical claims. So, but the problem that we kept running into as we were talking to health plans was the why, because they would say, well, why? I mean, I actually had a chief medical officer say, why would I ever want to prevent someone from getting diabetes? Because I get paid more when someone has diabetes. And it really broke my heart. But the problem that we kept seeing was this wrong pocket problem, that if a member was only going to stay with a particular health plan for, months or 1 or 2 years, then it was always through the lens of what interventions should I invest in that I'm going to get a return in a very short period of time. So that led to the concept of Noble. On the next slide, back in December of 19, I got together with my co-founder, Elizabeth Dreiser, and she had been leading the transformation of the Alliance Healthcare Foundation in San Diego. And we had a big whiteboard, and we said, if we were going to start from scratch, how could we solve what we're calling the wrong pocket problem? And when I refer to payers, it could be any risk-bearing entity. It could be government, it could be providers, it could be payers in the traditional sense, which are health plans. But, the issue that we were trying to solve for is that there are transient health plan member populations. A lot of the interventions around social determinants of health, while inherently we all believe that there is an ROI, there really is an intervention outcome uncertainty, both about the intervention, but about which providers of those interventions are actually driving the greatest outcome. And then how can those health plans or payers actually look at these investments as a security, where they're actually going to get paid back for their investment, as opposed to as an expense. And so we're also, Lori, I love your concept, like how can we actually leverage the power of multiple people coming together and trying to solve the problem collectively, as opposed to each individual person sort of, or health plan doing it themselves. So the next slide, the model that we came up with, we're calling it a market as a service or a mutual membership healthcare market exchange. And the whole purpose is to align incentives across the payers to make whole person scaled interventions with long-term returns. So it's actually creating a virtual single payer. So if you think about a giant risk pool that's sitting on top of the existing payers, that's longitudinally evaluating the investments that those payers are making, extracting value, and then redistributing those funds across the payers. So if one health plan is making an investment and another health plan is getting a healthier individual, the first health plan will be paid back for that investment. So it's creating a futures market, which is sort of it's a healthcare play, but it really is applying a lot of fintech principles to inherently the wrong pocket problem that disallows health plans to think about this as an investment. And we're also looking at markets like Maryland, where the state is actually looking at, similarly, a percentage of the profits go back into a community fund. And you can do great things with that. And we're organized as a B Corp in Delaware, which is a public benefit corporation, and looking at something similar where the value that we're extracting from evaluating these interventions over time would actually go back to the community, but the bulk of the return on these interventions would actually go back to the initial investor of those services at the payer level. So that's a big concept. We're getting quite a bit of traction in payers that have regulatory tailwinds like CalAIM in California, Colorado, Maryland. I actually think Arizona has enough organization and traction to be a really interesting market for this. So even though we came up with the business model in 19 with COVID, everybody went, whoop, COVID. And then, we don't have single payer. We won't have single payer. The ACA is alive. And I think there's increasing realization that social determinants of health have such a huge impact on people's health. We have to figure out a way to create a sustainable financing mechanism. So I've been participating with groups in Health Evolution Summit and CEOs of health plans, and we mapped out all of the different ways that social determinants of health are currently financed. And the most sustainable are grant funding and some public-private partnerships, but really trying to figure out a way of creating a long-term sustainable financing mechanism that will encourage health plans to make these investments is really what we're trying to do with Noble. So this is what it does. It tracks interventions and related costs by an individual health value record. So look at a longitudinal record over time. We also we have some of those assets with Health Currents and some other things in Arizona. And then it creates and determines and manages cost savings. So really the IP here is the concept of translating value and the ROI of the intervention investments into what we're calling a health value unit. So think of almost like a carbon unit. And then we're managing the attribution by payer, intervention, individual over time, allocating the return across the payers, and then paying those returns longitudinally to Noble market investors. So we're actually trading health value units. So, and then the business model for Noble is to take a percentage of those transaction fees or sort of trading fees. So it's a very different model of taking sort of a fintech and applying it to healthcare, but it's the only one that we could figure out that if we wanted to start with a whiteboard, we could actually create a sustainable model. So this is how it actually works in practice. Health plan joins the Noble Market Exchange. So the markets that we're initially launching, they have sort of a closed payer system of payers that have traditionally worked together. We have strong relationships, Elizabeth and my co-founder, with the executive leadership of those payers. There are regulatory tailwinds to do this, and there's it's sort of ripe to do this, and there's several markets across the country. So the health plan establishes a persistent member data feed with Noble and creates that health value record over time. The health plan has agency to actually deliver the interventions that they would like to deliver for their member population, and we're just tracking the fact that they're doing interventions. Now, long term, we may go out and get $1 billion and be the bank. So the bank is actually investing in these interventions over time, so we can actually provide persistent interventions and SDOH services independent of the payer. But that's sort of the phase 2, because I think one of the barriers to this model is just making sure that that there isn't a barrier for the payers to actually lean in and provide the investment in these interventions. Then we track over time, we attribute the value, we extract the value into a health value unit, so assigning a monetary value, and then facilitates the distribution among the health plans. And it's been interesting to talk to the payers, and they said, yes, we actually want to be the financial intermediary, not only to maybe our ASO clients or our, ourselves and across our business lines, because sometimes a health plan may be investing in the Medicaid plan, and then the fully insured plan gets a healthier person, and they don't have a way of allocating those funds even internally. The other concept is to create an annuity for people. So what if people participated in chronic disease prevention programs, and if they did, they created an annuity over time for themselves, so they could actually get paid back or use those funds over their lifetime. So this is how it works. We're early days for us, but I'm really encouraged with, so far, the market, at least interest, in moving forward and figuring this out. Next slide. So this is the value proposition. Laura, you had the same thing, like it's allocating the returns, but it's also reducing the administrative expenses to offer these new benefits when you're pooling resources and doing through a single entity. So we are not delivering services at all. We're the financial mechanism that's looking to extract value from the fact that people are investing in these, and then somehow giving them a payback or an annuity, as opposed to them looking at it as an expense. And then, what's been interesting about this as we've been talking to the payers is, while we looked at this through the lens of social determinants of health, the payers have actually brought up lots of different other types of interventions that have long-term returns that they also struggle to invest in. So severe mentally ill, transplant, novel gene therapy. So if a payer is going to pay $2 million for a cure for sickle cell anemia, how do you amortize that cost over a person's lifetime? Because there really isn't a mechanism other than some of the payers talking to the pharma companies around, a 5-year payment plan. Well, that doesn't even really help payers who really, have a difficult time with a single payment of $2 million for a member that may only be with them for 12 to 24 months. So this is what we're working on. I'm excited that we're here in Arizona. Would love to engage with anyone who just sort of wants to help us think through this. And here's our contact information if you're interested in being thought leaders or thought partners. So thank you so much.
Okay, well, thank you so much, Brenda. It's great to hear from you. And good morning, everyone. My name is Hannah Scott. I'm the Policy Director at the Arizona Community Health Workers Association, and I'm so happy to be here today with all of you. So to begin, I just want to tell you a little bit about the Arizona Community Health Workers Association, or ASCHO for short. So we're a statewide organization of community-based advocates, and we advocate on behalf of community health workers throughout the state of Arizona. We were formed officially in 2001, but we had been working kind of more informally for years before that. And our work really stemmed out of the original work of different Native American women throughout the tribal land of Arizona who had traditionally worked as community health workers. So since then, the model of community health workers has been studied and more formally established, and we represent the collective voice of the community health workers in Arizona. So to give you a little idea about here in Arizona, what we're doing, we serve in all 15 counties and in 19 tribes in Arizona. And there are over 1,000 community health workers working in different capacities in different spaces throughout the state. So our advocates are all different individuals. Some are community health workers themselves, some are researchers, Some are people who work for health plans, and some work at health departments. We're a very diverse group. So we come together on a monthly basis and create a space where everyone can discuss what they're seeing in the fields. And based on those discussions, we do different work to support the work of these CHWs. So a community health worker is a frontline public health worker, and they're typically trusted members of the community, and they have a deep understanding of the community that they serve because they typically are from the community themselves. So they serve as a liaison between healthcare and social services systems and the community members. So because of this unique perspective and experience of a community health worker, they have a deep understanding of the social determinants of health, and they're able to really take the social determinants of health in consideration through their work. So often some of their work will involve addressing issues such as housing insecurity, the loneliness and isolation that individuals faced, especially now throughout the pandemic. They've addressed issues of food insecurity, and one of the main things they work on is chronic disease management. And now throughout the pandemic, they've additionally been huge advocates for the COVID-19 vaccine, for explaining to community members how the vaccine works, how people can access the vaccine, how testing works, and how they can access testing. So through ASCHOW, we provide continued training for our CHWs so they are able to adequately address the ever-changing needs throughout the community. So through this, we're able to advocate on their behalf with the changing issues, and they're able to provide further education in the community. And throughout the community health workers movement in Arizona, in 2018, we passed HB 2324, which was the voluntary certification for community health workers bill that passed here in the Arizona State Legislature. And what this did was formalize our certification process. So this could lead us as community health workers and as an agency towards more sustainability and more secure financing for our community health workers within our health system. So though this bill passed in 2018, we've been since going through the rules process with the Arizona Department of Health Services. This is a very timely time to talk about this because just last week we started the public comment period with our bill and the rules. And so likely in the next coming months, the rules process will be completed and we will, kind of finally have this sustainable mechanism with our certification. So something that we did in 2020, amid the pandemic, we did a survey in partnership with the Arizona Prevention Research Center at the University of Arizona. And through the survey they surveyed 27 different organizations throughout Arizona, which were employing 371 CHWs. And this represented individuals across all 15 counties in Arizona. So the different locations that were surveyed consisted of health centers, tribal and county health departments, nonprofits, hospitals, health plans. So a very diverse and accurate, I would say, representation of where CHWs work. And through this survey, we identified some challenges and some positive things and ways to go through this survey. So we identified that 48%, or almost half of CHWs, were paid less. Were paid less than $15 an hour. And 52% of the positions of CHWs did not have a formal career ladder or the ability to continue on in their career in their position. But the positives that we found from this survey was that 72% of organizations wanted to expand their CHW programs, and 44% of organizations did have sustainable funding mechanisms for their CHW programs. So from the survey, we felt energized during a very challenging time here in Arizona throughout the pandemic that individuals did feel they had sustainable funding mechanisms even prior to our official certification process going through ADHS. And so we found that encouraging and believe that now, as we continue through the rules process with ADHS, there will be more sustainable funding mechanisms available for us, hopefully through Medicaid reimbursement and through Medicare reimbursement. And so we're feeling optimistic about the future and excited to explore these different options. So I would encourage you all to please connect with us on social media, and we have our email address here on the slide. So please feel free to connect to us and reach out. Thank you.
Thank you, Hannah. On the night of April 29, 2020, we received an email from Yolanda, a cry for help. You see, that night her boyfriend became a different person. In a jealous rage, he physically abused, raped, and almost strangled her to death. She recalls waking up in the emergency department, not knowing where she was, but being introduced to the advocacy center. They referred Yolanda to NOAA's community resource team for help. Her email that night said, "My mouth and teeth are messed up. This is an emergency. Can you please help me?" Of course, our community resource team sprung into action, but our team knew she needed more. We were able to help Yolanda receive dental services. We connected her to our medical and behavioral health team. And today, Yolanda is in a safe living situation with her sister, healing from this traumatic event. And most importantly, she can smile. During the height of this pandemic, while our team had just launched telehealth services, added psychiatry services, and was working around the clock on all things COVID, our team knew that our community needed our help, and our journey towards social determinants of health moved at an even faster pace. My name is Wendy Armendariz, and I proudly serve as the CEO for Neighborhood Outreach Access to Health. As I mentioned, our journey with SDOH launched with Screening July of 2020, with the goal of improving health, connecting resources, and integrating SDOH in our overall care model. So when you look at our care model as a community health center, we truly believe in whole person care and try to wrap as many services as we can for our patients. We proudly serve our patients in the Metro Phoenix area, covering Scottsdale, Phoenix, and Glendale through 9 health center sites, caring for over 40,000 lives and growing. In July, when we started our SDOH screenings, we launched screening adult patients, asking 2 questions around food. In the past 12 months, were you worried you would run out of food? Or in the past 12 months, did the food you buy just did not last and you were worried that you couldn't buy more because you didn't have the money to do so? So our patients responding yes to any one of these questions were referred to our community resource team for follow-up. The community resource team then does their amazing work connecting patients, conducting the rest of our SDOH screening, asking about housing, transportation, safety needs, and social support. And from that screening, we then refer to our partners, our community-based organizations, to help connect all of those resources. And so what have we learned so far? We recognize that there's lots of great value, and our data is telling us that when we intentionally screen patients in our health center, we're more successful in connecting those patients to our resources. So while we had 3 pilot sites asking these questions in clinic, referring to our community resource team, our other sites were simply referring, not talking to the patient or asking these questions in clinic, but referring to our community resource team. And the data here is telling us that by screening intentionally, we're more successful. And so we're a great example of a medical model that meets people where they are. What we're also learning from our data, we just don't have enough data at this time, and really data that speaks to the impact on cost. What we're working is to model that out, make system changes in our electronic health records that will help us track that. We also want to remind that this pandemic is still ongoing, and the ongoing of this pandemic will have some long-lasting effects. And so from our perspective, we still need to continue investing in staffing resources, the IT resources, system changes, and all the data analytics that go behind this. Some of the challenges, opportunities that we have been seeing in terms of SDOH, we're finding great success with food when we integrate those food resources on site in our clinics. We have an incredible partnership with our Desert Mission Food Bank partners, and we've piloted mobile food pantries. We also provided free food bags during our COVID vaccine events. And so we're looking to partner even more and possibly expand to more of our sites. From a housing perspective, we're seeing lots of challenges to finding affordable housing, but also navigating the different systems is challenging. I think that's where we're finding our community resource team is really making a difference, making some progress, finding ways to help with application assistance, helping patients find the documents that they need or the information that they need to apply so that they're not lost in the shuffle, they're not waiting long days to get the housing support that they need. And from a safety and housing perspective, we're just not finding enough emergency shelters, especially for patients like Yolanda. From an opportunities perspective, this is where we get really excited and really appreciate Hannah's work. We are looking at a community health worker model, one that is community-based and that will help us not only connect with our patients in the community, but provide general education, possibly help with assistance for appointments, and also really work together and integrate with our clinical teams. We're finding that patient navigation and support is critical to making sure that we connect our patients with those resources. That all takes resources to make that happen, and really appreciate all the discussion about grants. That is helpful to start, but we also need a stronger reimbursement model that will make this work sustainable, and reimbursement that will support both the organizations that are doing the screening on the front end, but also the organizations that are providing and delivering those services. So we appreciate your time, your partnership, and the many ways you support our community. My contact information is here. You're welcome to reach out if you have any questions. If we can share more about our pilot, we would be happy to do so. And hopefully in the future, we'll be sharing some more updates on our progress. So we're going to look at the chat. It looks like we have one question from Becky, and Brenda, I think this came up when in your presentation. The question is, how does your plan compare to the HB 21-1232 public option bill that is now being discussed in Colorado?
Yeah, so Colorado introduced a bill that basically said if the existing health plan payer provider incumbents didn't reduce healthcare costs 20% in 2 years, the state was going to institute a public option. And I think, honestly, that's going to happen more and more, realizing that misaligned incentives are driving a lot of the lack of investments that we need in things like social determinants of health. So in absence of a single payer, I think at the state level, folks are trying to determine different types of financing models or structures that would align incentives. So Colorado is an interesting market that we're looking at, particularly because the incumbent payers and providers who have delegated risk are so motivated to figure out how to lower costs really significantly in a very short period of time. And we hope they can do that by making some of these types of investments.
Thank you, Brenda. I see there's another question from Jennifer, specifically to myself, and asking if I can speak to the job titles of the individuals providing screening. Is this occurring at the front desk and office? Is there a warm handoff to a person with a different job title providing additional screening? Does all screening navigation take place in office, in the exam room? I'm happy to speak to that. We actually have our medical assistants screening, asking those 2 food questions in clinic in the exam room. So they're the ones with the patient asking those 2 food questions. If the patient responds yes to one of those questions, there is a referral that's sent to our community resource team. Our community resource team right now is off-site via telehealth. And so they're following up with the patient via phone or via video. And our community resource team, from a community health center standpoint, they're also the eligibility team, or sometimes referred to as the eligibility team. That is our community resource team. So they're able to take that screening and do the rest in terms of connecting resources, et cetera. I'm hoping that provides enough information. By all means, feel free to reach out. I'm happy to share more, share our model. We are looking right now to bring back our community resource team in clinic, always having folks present to do that warm handoff. So we are in the works to change our workflows a little bit to be able to help support on site. And then I see a question from Theodore. How can we use the increase in telehealth to promote vaccine education to underserved populations? Hannah, would you like to? I'm happy to chime in.
Yeah, you can go ahead and take that.
Sure. All right. So I think from a telehealth perspective, we are finding some great success with our underserved populations. They're using their telephones. If they're able to, they're using their smartphones for video visits. I agree, community health workers can be very helpful to provide that education. So as we develop our model, that's one of the areas that we're looking to be able to offer, because we are seeing some resistance when it comes to the COVID vaccine. And so I think that's a great opportunity to provide that education via telehealth.
Yeah, and this is Lori. I would just note too exactly what you're saying, whether it's that education through their care managers or through telehealth. We find that, sometimes it's even education multiple times. And then what I know at Mercy Care Access, all the health plans, we're really trying to look at ways to bring that vaccine to individuals. So kind of whether that's in the home or, in a assisted living center or things like that, but really give them that option right there just to take some of those barriers away from, having to schedule rides or figure out where to go and all of that. So sometimes it's even, taking away some of that work in the process. And even as Wendy noted earlier, if you talk about housing or SNAP dollars or things that you want to try to connect with the process to go through that, that's where we really do those community health workers or care managers or providers that have those kind of community resources just really can take away some of the stress in getting connected to the services that are out there. But we know with vaccine, that'll, continue to be something that we want to kind of promote and think of other ways to kind of reach individuals with such an important potentially topic. So.
Thank you, Lori. So we have another question from Marcus. Brenda mentioned helpful tailwinds that exist in certain states. For all of our panelists, I'm curious to hear about your thoughts on the SDOH referral networks, closed loop referral networks, such as the network that Access and Health Current are currently launching. How can such networks be helpful to your work? What do we need to do to ensure these networks are successful?
Yeah, I can kick it off at first. I mean, there's so much friction, as you guys have all identified, getting people with needs to the right services that meet those needs. And then I think just as importantly, understanding whether those individuals receive those services and those services actually were beneficial to them. So organizations like NowPow, Unitas, Healthify, Aunt Bertha really brought the sort of the 211 directory into the 21st century of seamlessly allowing community health workers, community health advocates to identify those resources that were both available to those individuals and potentially covered by their health insurance. It solves part of the problem. It helps the problem of the referral. It doesn't solve all of the problems. So I think it's a step in the right direction of helping increase access to services because there's a more comprehensive, easily digestible directory available for folks. But it doesn't facilitate the payment for those services yet. So there really isn't a connection between referring someone into a service. And in fact, there's actually an inverse issue where now that we're making referrals easier and we're identifying more individuals with that need to address different social determinants of health, it's actually increasing the utilization of those services among organizations that are traditionally grant funded. So you're increasing utilization among organizations that traditionally have a fixed capacity. And so in absence of a sustainable mechanism that actually can pay for those that's tied to utilization, we're creating friction. So really it's I like to look at how we can continue to put in models that can reduce friction and get people the services that they need.
Yeah.
Okay, this is great too. Oh, go ahead. Sorry.
Yeah, I would. Sorry, Lori. I would echo what Brenda said. And from Ash Chow's perspective, we, as community health workers, we want to be those individuals a part of this referral network because of the relationships that CHWs have in the community and how we know that they can get through to these higher risk individuals. But without the funding mechanism, as we've been, waiting for our voluntary certification to pass and go through the rules, so then we can move on towards reimbursement through Medicaid, through access, et cetera. That's really what we are unfortunately have to kind of wait for and continue to work for so we can get to that point.
Yeah, this is Lori. I was just going to note as well, back to Marcus's question about I'm really excited for Arizona, having the NowPow as just a single solution for everyone. I think from an administrative perspective, hopefully that's beneficial really to everyone, whether it's the providers, the CBOs, the health plans, others, and really allow us to get that data. And I think to your point, it's how do we work together, whether we incorporate that through payment mechanisms or, allow me to get dollars because living off grants, to your point, is like a fixed dollar. And then to your point, it's so important and you're utilizing all those dollars, but how do we really make it a sustainable model, no different than we have with other parts of the healthcare system. So I think it's a great thing for all of us to be working on together.
Yeah, I think really the goal around those social services agencies is not to medicalize them, but to legitimize them, because the last thing we want to do is to impose the same types of constraints that are so difficult in a fee-for-service medical arrangement around, compliance and regulation. I'm like, it's for people in a church, so legitimizing and tracking results and again, using community health workers to make those connections is so important without medicalizing those resources, because that's not their purpose. Although we all know that how much they can impact people's, the huge impact they can have on people's health.
No, I agree. Thank you all for your comments. I agree with and echo a lot of your points. And from our health center standpoint, agree with the resources. We need the boots on the ground with our community health workers. We are really excited about this closed loop referral because in our pilot, we're actually tracking, and it's a lot of manual work figuring out, did the patient actually get there and receive the service, or what else can we do to make sure that patient gets that service? I worry about our community-based organizations and the systems support that they're going to need to make this transition. And so that's where I think we're in a good place and are excited about NowPow, but some of our community-based organizations may just not have the capacity or sometimes the technology to do that. But I think it is a promising, and again, using multiple resources can help us provide those resources for our patients. I see another question from Jennifer for Hannah. Thank you for the presentation on CHWs. I'm wondering whether and how your advocacy for CHW relates to the Arizona Recovery Support Specialist and Family Support Specialist workforce, i.e. persons with a lived experience of recovery for themselves or a family member working in the area of mental health and substance use disorder recovery. Lots of folks in primary care with an unmet mental health or substance use need, as we know. Should love to chat more in depth offline for more information as well. So Hannah.
Yeah, hi Jennifer, thank you so much for the question. I am not sure if we are directly, we have so many community health workers doing such great work all throughout the state. I'm not sure off the top of my head if we have individuals working specifically in the program that you are mentioning, but I would love to follow up with you afterwards to further discuss this. So thank you for your interest. Thank you. And I think also Dylan had a question in the chat that, if that's okay, that looks like a great question that I'm excited about.
Yes, thank you. Do you think the health sector will emerge from the pandemic with a permanent, renewed commitment to health equity after seeing the disparities so clearly with the impacts of COVID?
This is Lori. From a health plan perspective, I think that's absolutely where we're going. And really, I think we realize that we're looking to get better data, to really develop better programs, just a renewed real focus on it. I know Access is working on that. Health plans are working on it. And I think for all of us, it's a matter of how do we come together again, right? There's so many aspects of this. How do we come together and really help solve from a broader community and kind of share the learnings and information that we all have. But I absolutely expect kind of absolutely a renewed commitment and kind of focus from honestly the whole healthcare sector. So I think it's a great question and right on point. So.
Yeah, I would say that I'm optimistic, and I hope so. I think those of us who have been working in public health for a while have seen these inequities and have been committed to health equity, but we haven't had the funding to really fully engage with this. I would encourage folks to look into the Arizona Prevention Research Center and to look into their work and research that they've done on health equity. And I think that we are excited about the American Rescue Plan Care Act funds, and we hope that those funds can really act as, to really stimulate and, support the next generation of the public healthcare workforce. And we hope that that will be directed towards health equity and that this will continue.
Yeah, I would agree. I mean, the state and county, city got billions of dollars a couple of weeks ago. And I think the first tranche of funding was, let's get it out as sort of more stimulus very quickly. And I think they're being very thoughtful around this tranche, around how do we actually create sustainable models and not only just address individuals impacted by COVID and their recovery, but all of the leading risk factors that disproportionately impact communities like obesity and diabetes. And I just think we're at this inflection point where people recognize that there's an opportunity to step in and improve the health of vulnerable communities that led to the disparities with the COVID virus.
I agree. From a community health center standpoint, very exciting. I think very much ingrained in the work that we do every day. And so to have a spotlight and an opportunity for all of our healthcare partners to come together and partner, I think it's a great time. And yes, I think this will continue and really heighten the commitment from all of us, from all of our healthcare partners. So it looks like we have one more minute. I don't see any other questions in the chat. To my fellow panelists, thank you so much for your time, for your leadership, and thank you to all of our participants for joining us today. Our contact information is available. Please feel free to reach out and have a great rest of your day.
Thank you.
Thank you.
Thanks.